Hello, everyone. I am going to present today about our technological response and to, as you said, the global pandemic. So today I'm going to present how us as the Francis Crick Institute was repurposed to become a diagnostic testing facility using the technology that we have available to us, and in collaboration with partner hospitals and an established diagnostic laboratory. So I'm just going to go over our sort of journey into that area. So just to introduce myself, I am Karen Ambrose. I'm the Research Data Services Database Team Lead here at the Francis Crick Institute. So for those of you who may not be familiar with the Francis Crick Institute, it's a biomedical discovery institute dedicated to understanding the fundamental biology underlying health and disease. It's located in central London, in the heart of King's Cross, and is a purpose-built building for scientific research. To date, as far as I'm aware, it's the largest biomedical research facility under a single roof. And I think that record still stands at the moment. So under the hood, there are 1,500 scientists and support staff working collaboratively across the STEM disciplines. Our work is mainly to help us understand why disease develops and translate discoveries into new ways to prevent and diagnose and treat illnesses, such as things like cancer, heart disease, stroke, infections, and neurodegenerative disease. So as you can see, lots of areas of research are taking place. So just to provide you with a few stats about the Crick, and I'll probably refer to it as the Crick because generally we kind of shorten its name, although officially it is the Francis Crick Institute. So out of 1,500 staff, there are about 1,250 scientists, which make up over about 120 research groups. And then there's scientific platforms along with 250 members of support staff that attend to sort of the infrastructure and operations that support the running of the Institute. Within the Institute itself, there are about 30,000 pieces of scientific equipment, and the building itself is, in terms of stats, is about 170 meters long, and it's split into about 4 quadrants. So there's a north, south, east and west section of the building. In size, it's about equivalent to 17 football fields, so as you can quite appreciate, quite large. In terms of height, it's 12 floors, which are 8 floors above ground and 4 below. And within the building, there's about 1,553 rooms. The main ethos of the building is to encourage collaboration. So as you can see from these lovely pictures of the inside of the building, there's lots of areas for groups of scientists, groups of operations staff to sit, collaborate on different projects, discuss different issues, and help each other out where required. In terms of our power, we are connected to the main grid, but we also try and generate our own electricity because we've got solar panels on the top of the roof as well. So we try to be as sustainable as we can in respect to the size of the building. Internally to the building, in terms of culture, there's about 70 plus nationalities under one roof. And also we've got 2 active Nobel Prize winners as well. So in relation to the science that's carried out in the Institute, our strategy statement is discovery without boundaries, which embodies our areas of research around about 7 core research areas. And these are, as you can see, growth, development, health and aging, human biology, cancer, immune system, infectious disease, and neuroscience. They all kind of feed into our strategic priorities, which are to pursue discovery without boundaries, create future scientific leaders, collaborate creatively to advance UK science and innovation, accelerate translation for health and wealth, and engage and inspire the public. The main aim is to translate discoveries into ways to solve human health challenges and encourage innovation. So, as I said before, in excess, we have about in excess of 100 scientific labs. In addition to that, there are 16 scientific technology platforms, or STPs as we call them. And these provide a core service. So, for example, electron microscopy is one of our core services. Scientific computing, which my team is part of, is one of the core service. And what that allows us to do is to centralize the expertise in one area to service multiple teams. So for example, for teams like electron microscopy, the instruments that they use are very expensive. So each lab wouldn't be able, it wouldn't be feasible for each lab to be able to afford and purchase individual instruments. And also there is a space consideration within the building. So in order to make the best use of the specialism that we have, we kind of centralize that, harness expertise, and we can also contribute to the continuity of service and service the science groups at large as well. So it kind of makes sense in that respect. So just a little bit about myself. As I said, I introduced myself at the top of the presentation. So I've been the Research Data Services Database Team Lead here at the Crick for the last 6 years. I manage a team of 4 very bright people with a mixture of expertise across database administration, development and application development. We have responsibility for the scientific database within the Crick, as well as the operational database, and we also contribute to the data management within the Crick itself. I previously worked at the Wellcome Sanger Institute in Cambridge, and for those of you who are not aware, they were responsible for sequencing 1/3 of the human genome as part of the worldwide collaboration project. So quite interesting times as well. In addition to my day job, I also do a lot of work around the EDI and equality space as well. I'm the chair of the Race Equality Staff Network here at the Crick. I'm a member of the Athena Swan Steering Committee, and I also lead on the Race Equality Charter Group as well. So now on to the main point of this presentation. So just a little background of how we actually got involved in being a diagnostic testing centre for the COVID-19 effort. So in terms of the consortium, this was formed on the 19th of March. So this all kicked off very early in the year, and following discussions and meetings, collaboration was formed between the University College London Hospitals NHS Trust, the Health Services Laboratory, which I'll refer to as HSL, the Institute of Cancer Research, and us, the Francis Crick Institute. Within 2 weeks, following the initial meeting, the consortium had set up a high throughput RT-PCR COVID-19 diagnostics assay within our research institute, so quite a quick turnaround. Following an accreditation with HSL, the pipeline, which is an extension of HSL, which is an accredited lab, was operational and up and running by early April 2020. We put it together with a mixture of on-site and virtual working. So during that time, some people were on-site, but a lot of our staff were working from home, and we actually pulled that together with a mixture of that working environment. The main aims in setting up this pipeline was to minimize dependencies on reagents, which were in short supply at that time. So using our internal expertise, we devised an assay that did not have to rely on the main reagents that other testing sites were using. We also had to provide resilience to that pipeline and to provide a scalable platform to screen hundreds and thousands of healthcare workers and patients per day. So that were the main aims for us being involved, setting up the pipeline and moving forward with this initiative. The main driver for our involvement was summed up nicely by our director, Sir Paul Nurse. So as he felt testing was being the essential part of the national effort to tackle the spread of COVID-19. So therefore, he likened the institutes like ours come together with, as he said, a Dunkirk spirit the idea that we can collectively work together to have a huge impact on the national testing effort. So as I mentioned previously, we collaborated with HSL, which is the main sort of accredited diagnostic lab. And this allowed us to develop the main sample feed into our process, to be able to process those samples and return the results. At the start, our main sample source came from the hospitals within the University College London NHS Trust network. But we were aware that there would be other sample feeds which would require a route into our system. And ideally, we would need to identify that main point of contact and agree a standard uniform way in which sample information will be fed into our pipeline to be processed. Because our key aim was to ensure that the integrity of the data was maintained and ensure that we only receive sample information required to support the sample processing. From the start, when we were in initial discussions with HSL, we agreed the format and ensured that we didn't receive any patient identifiable data, which for our part of the sample processing pipeline was not really required. So we didn't really need to see any patient data, it's only the identification of that sample. So as HSL, as you can see from this diagram, was the main sort of interface into the hospitals and GP practices and care homes, they already had the systems that contain the patient data. So it was agreed that HSL would manage the patient data, maintaining that data confidentiality. And we would now have the sort of the main, and so HSL would now be the main interface into those heterogeneous systems which would feed into them, and they would then submit their sample information for processing to us. So in terms of, so let me see. So then at the end, we would then return the results back to HSL, and they would ultimately return the information back to the patient at the end. So that was kind of the process that we agreed with them, and that seemed to be the best way to proceed. So leading on from that point, so maintaining the end-to-end data integrity was our main focus. From the start of the process, samples would be barcoded from source. The samples would then be tracked all the way from source, which would then be prior to us being receiving them by prior to being received by HSL. So initially, the samples would come to HSL pre-barcoded. They would then register them in their system. They would then submit those samples, pre-register the samples with our system by sending us an order file. So that would be the Crick order receipt. And we would then preload that into our system. We would then physically get those samples delivered to the Crick. So at that point, we would then see those samples and be able to scan them into our system, having already had them pre-registered. The sample would then go to be processed and then go to the RNA extraction step, where the virus will be deactivated. Then that sample will then proceed to the RT-PCR step, which processes the sample and produces the physical output file for the reporting step, where the PCR output is checked by reporters and who confirm and save the results, and finally ends with the results being passed back to HSL. So we go through about 7 different stages in terms of receiving the physical sample and producing the results at the end. In each one of those steps, there's an auditing just to make sure that we've received the sample that we're meant to receive. We know where that sample is in the process. And if there's any problems with that sample, we can then report it and send it back to HSL and request a retest via HSL should we need to. When we receive the sample, we also do a check on the integrity of that sample to make sure that it hasn't been damaged or is leaking in any way, because we need to ensure, we can't have any samples that are contaminated going through our pipeline at that stage. So as you can see, there's sort of a mixture of technologies that we've used throughout this process to track the samples through each stage. So from the previous diagram that I've just gone through, you can see sort of that illustrates the physical process, but in this in-depth diagram explains a technology process which supports the sample tracking and reporting pipeline. So as I said before, the sample IDs are pre-registered with our system from HSL prior to the physical sample being delivered to the Crick. We receive the sample details electronically via an SFTP system or server, which contains the sample ID, the hospital number, the test type, and the test date, which is the main information that we need. This information is then imported into our database registration and integration system at this stage. On arrival at the Crick, the physical sample is scanned into the Crick Sample reception to be confirmed as physically received into our database registration. And at that stage, as I said, the sample enters into our workflow and is into our internal laboratory information system. This step allows us the ability to manage samples so that if we can identify samples that may not have arrived or if they're damaged. At the sample, as I said before, at the sample reception stage, we also check the condition of that sample. So if it's damaged or leaking, we cannot process it, and we register that sample in the system as a failure with a reason around to request a retest from HSL, because what we don't want is for that sample to just go into the ether. We need to be quite proactive in getting that request back to the ordering hospital so that they can reorder that retest from that patient, and there's no time delay in that process. But in terms of damage to the samples, as you can appreciate, this is live virus within the samples themselves, and we need to operate in a highly risk-averse environment. So we need to make sure that our staff are not at risk in terms of testing the samples themselves. The samples then move through the physical stages, and there is some integration with our main instruments that we use at different steps. Once the sample is registered, then it moves to the RNA extraction step in a 96-well plate format using the Hamilton liquid handler robot. The tubes on the machine are then scanned and associated with a plate ID, and the format of that plate is then uploaded back into the LIMS system and then recorded. So at that stage, we have kind of a handshake. The generated plate will then proceed to the RT-qPCR step for analysis. The plate format is extracted from the LIMS, so they know kind of the format and the orientation of each sample in each well of the plate. The plate is then the output files. The plate is then run on that instrument. The output files will be then generated, then are placed on our internal physical storage system. Once those results files are generated, they are then reviewed by a two-step reporter process. So they will then take those output files, have a first pass and look at the output and just confirm that the results that they're seeing are correct. And if they need to make any amendments, they'll make them at that stage. The output file is then passed on to a second reporter step. These are then uploaded into our bespoke web application, which was internally created for this particular process. And then that information is then accessed by external second stage reporters, who are then able to review the output and associate with each plate, look at the genealogy extracted and from our internal LIMS system. The results would then, once they're happy with those results, the results are then reported back to HSL. So we submit that information back via our SFTP server. And then the results will be processed and reported back to the patient through the HSL system, because as I said before, they have the patient data and information to do that. Those stats as well, in terms of the positive, negative results are then reported back to Public Health England through HSL system as well. So they will contribute to the government stats at that stage. So in effect, the reason why we were able to instantiate the pipeline so fast was because we could harness the existing expertise that we already had within the building. And it actually was a true indictment of the hard work of the staff involved. We were also aided by the technology we already had and the knowledge that we had within the building, which allowed us the opportunity to create and repurpose and extend to support the pipeline while ensuring that the data integrity was maintained throughout the whole process. So the next two slides, I'm just going to show you a couple of images for the applications and the instrumentation that we use to support the different stages and that underpin the different stages. We also had to incorporate bespoke functionality where required to support sample registration step, which feeds into the main limb system, which was in this case Illumina, which was Clarity Limbs. Both of these systems were underpinned by open source database technology. So for our general sort of tracking database registration, we had MySQL as a database backend, but for Clarity Limbs, it's mainly Postgres, respectively. These application layers were also integrated with the instruments being used along the pipeline to record the progress of the samples. So also in the picture, you can see that we have on the right-hand side, the Hamilton liquid handler robot, which supports the RNA deactivation and extraction step, which then also feeds back into our limb system. Then we go on to the RT-PCR process, as seen in the picture on the left. We have our sort of physical instrumentation and the output files, which are generated from the Quant Studio PCR machine and the physical files that we review here. In addition to that, we also had a bespoke web application, which was designed internally for this process, which allowed us to present the results and output files so that we could then support the second line remote reporters. The results would then be collated, as I said, and returned back to HSL via secure transfer route. They would then record those results within their system and return it to the patient. The web application, which is bespoke, was written in Python and Django with a MySQL backend, again, using internal expertise and the group that would develop that system. So to date, in terms of processing, we've processed up to about 150,000 samples with about 50 people working on the pipeline at any one time. Since the start of March, there have been about 300 odd members of staff involved in the development and the support of the pipeline to date. In addition to also testing healthcare workers and patients outside of the Crick, we've also implemented our own staff testing system to ensure our on-site staff are routinely tested as well. In relation to turnaround times, we've more or less consistently achieved less than 24 hours for about 95% of our samples to date. So we're not doing too badly in that respect. And in terms of our immediate plans for the future, we are currently, now that we have had time to bed in the process and see how it works, it's a case of reviewing the current pipeline, looking at how we can streamline it and increase capacity. Because as I said, we'd set up the pipeline effectively in 2 weeks and it's been running for about 7 months now. And I think we're at a point where we can kind of sit back and look at it and say, okay, how can we make this work even better? So I'm hoping that this provides you with a good overview of the work that we've done at the Francis Crick Institute and the staff's effort that have been involved in the last 7 months. If you're interested in finding out more about what we've been involved in, a lot of the information is posted on our external Crick website, and a link I've provided here as well for you to have a look at. We also made a point of publishing a lot of our SOPs around the pipeline. So the groups have put together the step-by-step process which underpins each area of the pipeline. And this allowed us to, and we were very keen to share that information with other institutes across the UK, who were keen to do a similar thing and weren't sure how to get started or where they needed to start. And this kind of helped sort of to springboard their efforts as well. We also managed to have some time to put together a publication about our endeavours. So, and this sort of just one of the publication we had published sort of explains how we managed to repurpose our institute into a diagnostic centre, and what we had to do, and the underlying assays and the development that was incorporated in getting that off the ground. And as I said, in true Dunkirk spirit, if you like, we shared our testing protocols with other institutes who were seeking to do the same thing. So as I said, this is some of the institutes that we've engaged with to date to sort of help them and sort of springboard their efforts into getting into being a diagnostic testing centre as well. So I suppose finally, it's all the final thing to say would be to really extend a big thank you to all the staff who were involved in this effort in terms of getting the Crick to making it a success and making the diagnostics pipeline a success in terms of where we are today. So that will be staff who work at the Francis Crick Institute, the Health Service laboratories, the Institute of Cancer Research, and the University College London Hospitals NHS Trust as well. So there's so many people involved, as I said, physically on site and virtually working from home, and it was actually quite an amazing effort from everybody. So, I'd extend major thanks to them. And also thanks to you all out there for listening today, and hope you have a very good day. Thank you very much.
Yeah, this was a fascinating talk that you just gave. It was really insightful what you did. I do have a few questions for you while we still got you. Got 2 minutes left.
Okay.
So I just wanted to ask, what do you think in your mind was the biggest challenge that you faced in putting all of this together and getting it done? Was it the short amount of time? Was it the pressure kind of externally of, right, this is being a global pandemic? What was kind of the biggest challenge that you faced here?
It was all of what you said. Mainly was the time, because from the time we entered into the conversation in March, we really had very little time to get this up and running, and it was mainly all hands to the pump, 24/7. Everybody was working, trying to, okay, how can we get this to work? What do we need to have in place? And you didn't really have time to think so much, but it was great that we had the expertise already in the building to be able to draw on, and for us to kind of come together and say, okay, these are the things that we need to put in place. And it really quite amazing in that respect that we managed to actually get it done in 2 weeks, because when it was first raised, we were like, no, that's not going to happen.
That's incredible.
It's incredible actually that we actually did it. So, big kudos to all myself and all the groups, all the people that were involved as well. So
awesome. Well, thank you so much for your time. I want to speak for everybody when we say thank you for all the work that you did in pushing this forward in these really important and trying times.
You're very welcome. Thank you very much.